Hello, this is Karen Suter. I am a Go Diabetes team coordinator. I'd like to welcome you to another webinar, one of a series being offered as part of our Go Diabetes project. All participants' phones are muted automatically as this webinar will be recorded. The recorded link will be available on our website, www.godiabetes.org, within a week. We encourage you to share with your colleagues all of our webinars that they have been recorded and are available on the site. Today we are very fortunate today to be joined by three presenters. We have Faye Brown, who is the Executive Vice President for the Georgia Academy of Family Physicians, where she has served in that capacity since 2002. The Georgia Academy is a 2,500 member organization, the largest physician specialty society in the state, and also is proud to be a co-founder of the Go Diabetes, along with the Oklahoma Academy of Family Physicians. Prior to her work with the Georgia Academy, she spent many years in Washington, D.C., where she worked with the American Academy of Family Physicians and the American College of Cardiology. We have Dr. Andrew Bazemore, who is the Medical Director for Policy Research of the Robert Graham Center for Policy Study in Primary Care, where he directs research and projects related to access to care for underserved populations, health workforce, spatial analysis, and health, and other topics. Dr. Bazemore remains an associate professor for the University of Cincinnati's Department of Family Medicine, where he also completed his residency training and faculty development fellowship. He serves on the faculty of the Department of Family Medicine at Georgetown University and the Department of Health Policy at George Washington University School of Public Health. And finally, we have Dr. Stephen Pedersen. He's a senior health policy researcher at the Robert Graham Center. Previously, as a sociologist and social statistician, he was on faculty at the University of Virginia and as a researcher at the Southeastern Rural Mental Health Research Center. He earned his PhD in sociology from the University of Wisconsin and an undergrad degree in sociology and anthropology from Haverford College. We're very fortunate to be joined by these folks, and without further ado, I'm going to turn the program over to Faye Brown. I will remind you, in case you have questions, you're welcome to use the chat function. We'll hold the questions to the end of the presentation, where I will read them so that they will be recorded, and then give the panelists an opportunity to answer your questions. Thank you, Faye, for being with us, and you've got the ball.
Thank you, Karen. I appreciate it, and I appreciate your leadership throughout this GO project this year and last year, and especially appreciate you hosting for today. So our goals for today are relatively straightforward, which is let's look at where we have, where GO has had an outreach over its 5-year history, and we're going to turn it over to the Graham Center researchers to really talk about, is there something that we can prove that we have had success by focusing on Go Diabetes in the family medicine setting. So the history of Go Diabetes is that we started out in 2008. GO was the acronym for Georgia and Oklahoma because it was the two chapters of the American Academy of Family Physicians that started Go Diabetes. And in 2008, we started out with just the residency programs in our 2 states. We found that it was wildly successful and expanded it in 2009 to 55 residency programs in 16 states. In 2010, we really began to change the curriculum so that there was the diabetes education with the overlay of incorporating tenets of the patient-centered medical home. And we also expanded to private practices. So in 2010, the curriculum changed slightly. We expanded it to 47 residency programs and then 61 physicians and staff from 37 private practices. The private practices were still just in Georgia and Oklahoma, whereas the residency programs were in 21 different states. And then we land on where we are today. We're in the middle of the 2011-2012 GO project, and we're supporting 39 residency programs and 19 private practices from the virtually, we've hit almost every state in the continental U.S. at least, and we concentrate on what we kind of call the Rust Belt and the diabetes southeast belt, where we have focused on our recruitment for family medicine private and residency programs. Why are we here today? Well, I'm not the clinician, so I'll just briefly go over this part because, but it's important for us to remember that we're in the middle of an epidemic. Certainly diabetes is affecting millions of people in the United States, both diagnosed and undiagnosed, and the future of the epidemic is grim, with their predictions that by 2050 that 48.3 million people will have diabetes. And most of those, if not a tremendous percentage of those patients, will receive their care in a primary care setting. Why we're here today and what we want to talk about is what the GO project team, including the lead faculty, talk about all the time, which is the importance of providing education to family physicians and their team, supporting the medical home, and ABFM maintenance of certification, as well as being able to initiating long-term and sustained change for improvement in patient care, quality of care, and overall health of the population. Why GO diabetes? Why not GO asthma or GO some other chronic illness? Well, GO is probably pretty perfectly tailored to have an overlay of other chronic conditions, but diabetes is the perfect chronic disease to begin with, or to continue the practice of culling your population of your patients and moving them along the tenets of the patient-centered medical home. And we certainly believe that GO diabetes is the perfect path. We have enough time that the practices can initiate the change and have the ability to auto-correct along the way if they have made over or too far-reaching goals, or they realize they're missing the mark and they need to come back and get more of the low-hanging fruit in terms of outreaching to your patients. Then GO diabetes has that ability, where we hope the practices are continually looking at their population to see what kind of additional attention do your diabetic patients need. And of course, we do a lot of celebrating successes and talking about how to hurdle the barriers. And in 2011 and 2012, certainly we've all gotten to know Rosita. Those of you who are a change agent or are participating in a practice or residency program, we hope you know Rosita well, as she is our case study where we look at Rosita across the span of her lifetime, a lady with diabetes, but she's got a lot of other things going on, and certainly we believe that Rosita gets outstanding care in a family medicine setting throughout her lifespan. At this point, I've given you the quick snapshot of where the GO diabetes is in terms of the numbers. We have engaged the Robert Graham Center to take a deeper dive and look at some of the statistics that they were able to cull from the metric analysis from the 2010 data. And with that, I'll turn it over to Dr. Stephen Pedersen and Andrew Bazemore to tell us more about the 2010 analysis.
Thank you, Faye. This is Andrew Bazemore. I'm the medical director for the Robert Graham Center for Policy Studies in Family Medicine and Primary Care. And before launching into a little description of our analyses, I want to make sure that I'm clear about what we do and why we have again, I see great value in this relationship with the Georgia and Oklahoma chapters. The Graham Center was born 12 years ago as an editorially independent division of the American Academy of Family Physicians. And it was, from the start, not only invested in effective policy making, but in making sure that we were reaching practices, reaching the frontline family physicians, and always able to and eager to assist innovative chapters like the Georgia Academy, Oklahoma chapters, and really superstars like Faye and colleagues who are trying their best to be the umbrella that brings best practice and frontline changes to best practice back to their constituents. So when we look at, as a center, at a 10,000-foot view at how to take next steps in advancing practice, I think it's important to note that in the wake of the Affordable Care Act, with an aging population, increasingly with comorbidities such as diabetes and many others, that it's abundantly clear that the demand for primary care is increasing. And not just for primary care, but for effective and patient-centered primary care. And for primary care physicians like those who participated in this process, who's not only willing to manage whole populations, but actually to study self and to practice as willing to study self. We do know also that within the primary care arena, that the lion's share of outpatient management belongs to family medicine. So for conditions such as diabetes, such as congestive heart failure, from cradle to grave, we have a particular responsibility and particular obligation to be the best possible managers in order to impact cost-effective change to the healthcare system. It's a fundamental tenet of any operation, be it in healthcare or in industry, that measurement matters, and that if you can't measure it, you can't manage a process. Yet doctors, just like anyone, start to feel a little contentious when they're told that they need to go and study themselves. And we know, and I know as a physician who is practicing, that when I am asked to go and look at how I'm doing, not only in the 15-minute encounter with an individual patient, but across all my patients, at meeting basic guidelines, well, I look something like this turtle when asked by my office manager. So I really applaud the participants in Go Diabetes for taking the time, which is not compensated in the current system, to take measurement seriously and self-study seriously and self-betterment. You would really be all-stars in the eyes of Don Berwick. We know further that chart review is a perfectly miserable process, and yet one that's so important to that self-study. If we can't look in the fashion that was provided by the Go Diabetes training across multiple charts in a convenience but a semi-random fashion and start to see patterns in our care, we just can't make advances in our measurement. So very briefly, as Faye has alluded to in the Go Diabetes intervention, we wanted to come in as an evaluation team and look in a Don Berwick fashion across change over time and how someone did in the pre and post period, before and after an intervention. And we knew that this is, because of time constraints and because of the nature of clinical practice, a difficult analysis to demonstrate real change in. The intervention has already been described to you as an effort to teach basic guidelines and principles of effective diabetes care. And we were looking at 0 and 3 month intervals across 78 physicians and 210 residents in multiple practices in the southern region to see what the changes in individual practice-wise diabetes quality benchmarks would look like. We were also interested in inter-practice or between-practice aggregate change over that time period, and in the specific measures of whether or not a clinician, before and after learning about guidelines for effective diabetes care, was counseling patients to stop smoking, was providing regular lipid checks, was looking at diabetes hemoglobin A1C measurements, foot exams, retinal exams, providing flu vaccines, proteinuria screening, and blood pressure screening. We also wanted to estimate differences across time and try to better understand whether or not the A1C, blood pressure, and cholesterol screening values were actually better concordant with guidelines in the post-period than were in the pre-period. I should give a caveat before handing off to Dr. Steve Pedersen that we really would not necessarily expect dramatic or even any significant change over this short time period, but it is the measurement, the process of self-study, and hopefully the habit that this forms of looking not only at 0 and 3 months, but continuing the habit so you're looking at more meaningful time periods like 6 months and 12 months that this process started that makes the difference. So I don't want you to be disturbed or daunted when, as Steve's about to show you, some of the results did not demonstrate significant change. And with that, I'm going to hand it over to Stephen Pedersen, our research director at the Graham Center.
Hi. The first set of results are for the residents. The next set are for the physicians. It's important to break them down because of the really substantive differences between those two groups. The way to read this is you have the list of measures, and then the baseline is the initial values for each of the physicians prior to the intervention, and then the follow-up column referred to the post results. And the p-values is a measure of significance. And then in general, anything that's highlighted has a p-value of less than 0.05. Again, scanning across these results, we find that almost all measures are statistically significant. with the exception of, at least for residents here, 2 different measures, lipid profile and A1C measured. But in general, all the measures are increasing with the exception of blood pressure checked, where you actually see a decrease across time. If you look at these 3 different measures, lipid profile, A1C measured, and blood pressure checked, you note that already the residents were close to 100%, so that in a sense it's hard to find more room for improvement. But again, you look at the other measures. Let's take stop smoking. There you find almost a 20% improvement between the baseline and the follow-up. Similarly, for retinal exam, a 10% increase. For flu vaccine, more than a 10% increase. So again, these results do show that across time in response to the intervention, there really is substantial improvement. The next set of results for physicians really tell a similar story. Again, here you're finding about for half the measures, there's significant improvements between the baseline and the follow-up. Again, those that that are already close to 100%, such as lipid profile or A1C measured or blood pressure checked, really don't show a significant improvement because there really is not that much room for improvement. These simply is the same results, different way of presenting them. So for those of you who enjoy bar charts, the top line for each measure is a follow-up, and then the blue line is the baseline. And again, you can see across multiple measures substantial improvements. This is for residents. Likewise, for physicians, you can see some of the measures, for instance, blood pressure checked are very, very close to that 100% mark.
We should certainly note again that there are limitations to what we call study like this, and this is really about, again, embracing quality improvement, which is less about purity of methodology and more about the process of constant evolutionary evaluation. The period of measurement may obviously be too short to capture the full intervention effect in this study. With a very small number of charts pulled and non-randomly selected, there may be some unpredictable selection biases that actually obscure the potential effect in either direction. And we may actually have some confounding influences on individual practice behaviors. Other interventions, things that someone is reading or learning or taking part in that would actually shape real differences in the management of diabetes far beyond and in excess to anything that Go Diabetes may have taught them. We want to note in conclusion that, again, there appear to be, in both the resident and the physician cases, some significant improvements, especially for those measures not near the maximum possible value of 100%. And that, again, the idea of this process to continually measure and evolve one's practice based on that measurement through what we've learned from Faye and subjective and qualitative feedback was particularly strong. And with that, we're going to hand this back off to Faye Brown to wrap up and give reminders about the Go Diabetes process for the next year.
Excellent. Thank you so much. And that was really that was very interesting for me to hear. And I've been staring at these numbers for years now. And I know that this is the perfect time for people to be directing questions either to the host or to the presenters, if you want, while we give you these reminders. We have a lot still. There's still a lot left of Go to go, which means that we have another webinar coming up on August the 1st. Please note that the research poster abstracts are due on August 1. We're looking for some robust research posters since we've been talking about it for the last 2 or 3 months now. Another webinar on the culture, the impact of culture on treating your diabetic patients. And then, not to be overlooked, but certainly to be circled on your calendar, we hope that there will be a packed room for the Go Diabetes Summit, which will be held in Philadelphia on Wednesday, October 17th. It will be held in a historic center very close to the AAFP Scientific Assembly, and it will be Wednesday afternoon as the annual Scientific Assembly with the AAFP kicks off. And additional agenda and registration forms will be sent out within the next 2 weeks. We do have limited seating availability, and this program is not to be missed. It is almost our favorite event of any of our GO projects, where we discuss and celebrate our successes, and we have our graduation, as well as we kind of purse our lips and cast our eyes to the sky as we review barriers that people have encountered. But we certainly want as many people who are planning on coming to Philadelphia for the AAFP Scientific Assembly and have been participating in GO, whether you are a change aide or are just a team member as part of a practice. We would love to have you come to that. And I now will turn it back over to Karen to see if anyone has dialed in a question or two.
Thank you, Faye. I will remind you, if you have a question, please enter it on the chat line, and I will read the question so that it can be recorded. We do have one question for our panelists so far, and that question is, if you were going to create a research poster based on this analysis, what would be the thrust of your poster?
So if I were crafting, and it really would depend on the poster audience. If I were crafting this for an audience of practice transformation conference attendees, I would really focus on not just the results, but on what actually took place in GO Diabetes that was a novel, innovative way of presenting an age-old process of quality improvement. And I think there are a number of those. I would definitely steer away from too intrinsically highlighting the tables, because at a 0 and 3 month mark, I can't emphasize enough that the actual effect of both measuring and of again, the specific intervention itself are unlikely to be fully captured, and spend more of my time highlighting what was innovative about the GO Diabetes process. Might include some of the qualitative responses gathered within my practice about what this meant, this active measurement meant in the transformation process, and might actually have a next steps section to my poster looking at how either I'm starting to innovate in looking at other comorbidities or in comorbidities with diabetes, in measurement generally, and adapting what was a first step towards the measurement process towards something broader.
Thank you, Dr. Bazemore. I have a second question. How do you avoid the problem of bias when you're pulling your own charts, even if they are random?
I think that really depends on what type of bias you're referring to. I prefer, if you're looking at methods for selection of chart, following one of any number of algorithms for random or sequential chart review, so that you actually do start with randomization in mind. And there are so many, well, there are a lot of those. There's not any one best practice. If you're looking at an electronic health record, you have a real advantage in the ability to either use a random number generator for your medical record identifier, or some sort of looping code if you have the IT support to allow that to be truly random. If it's a paper chart, depending on if it's alphabetized, organized by family, or geography, there are definite ways to, again, to randomize your selection, or at least come up with a sequential selection that allows you to or helps you to minimize those biases. You're always walking a fine line between an intolerable workload and having an adequate number of charts to minimize the, again, the possibility that you have non-random findings in those selected. And I think that really depends on the number. You have to assess the number of diabetics in your practice. You'd have to have some knowledge of, again, your total panel size to make that best guess, which is, I believe, why GO Diabetes has picked a nice round number 10 and stuck with it. But that could easily be modified, particularly with a little perusal of literature, to to better fit your specific practice patterns and your prevalence of diabetes. Steve, do you have any other comments there?
Really, the question is, what is most efficient? Is that you can think of looking at the patients in terms of when they visited the office. So if you want 10 patients, you can simply specify that you're going to take the first, third, fifth, seventh, ninth patient that comes through, or you can vary that, and you can perhaps every fifth patient. And as long as you're doing this over, say, a period of a week, you're getting the patients that are coming on Mondays as well as those that are coming in on Friday. And it's a fairly simple way. You want to make sure that you think about something like the time of day that they come in, which day they come in, to remove all possible biases. So if you know you have 100 diabetic patients over the course of a week, then you can decide you're going to pick, again, order them by time that they came to the office and pick the 1st, the 11th, the 21st, and so forth.
And one of the reasons that, again, in you're looking at a PDSA cycle, 0 and 3 months makes an awful lot of sense because it is time limited enough to make rapid evolutionary change in your practice patterns. One of the reasons that it would be nice to pair that with 0 and 12-month chart pulls and follow-up is that you avoid the seasonality variation that can influence your flu vaccinations, for example, your presentation for other conditions that might distract a physician in one season from caring for the chronic conditions as extensively as in another season, and to actually look at same time periods, over a longitudinal process to capture greater effect.
Well, thank you again, panelists. This appears to be the end of our questions and the end of our time, but I will remind those of you who may be listening as a recording on the website, if you do have questions once you've listened to the webinar, you're welcome to send those directly to our project director, and that is Susan@GoDiabetes.org, and you can find her website, her email address on the website. We do thank you for your participation today and hope that you found this webinar helpful. And if so, please look on the website, www.godiabetes.org, and look for the link under resources for the link to this webinar as well as those conducted earlier. We'd appreciate you sharing those with your colleagues. We appreciate your time and attention, and I hope you have a great day.
Thank you, one and all.